Good morning, Christa. I'm just letting you know that I did make you co-host, so at the point that we turn it over to you, you'll be able to share your screen if you have slides that you want to share. So, and we're just gonna, we usually don't get started until around 5 after we let people kind of trickle in, and then we'll do some introductions so everyone kind of knows each other, and then we'll get going. So just a few minutes still here.
Christa, shall we go ahead and get started?
Yeah, sure, we can do that. Did you want to start us off, Piper, or would you like me
Sure.
to?
Yeah, I'm happy to. Welcome and good morning. Good to see everybody. We're really excited about the Echo Clinic today. We've got a great presenter and a presentation from one of our learners. So excited to do that. As we typically do, we'll just go around and do introductions real quick. To start us off, we'll end with our presenter, who we will turn it over to talk about suicide assessment today. So I will get us started. My name is Piper Meyer-Kalos. I'm a clinical psychologist. I'm also an IRT on the Navigate team and one of the PIs of the EpiNet program. So I do both research and clinical work. And I will turn it over to Christa.
Good morning, everyone. It's great to see you all. I'm Christa Coudray. I worked with Piper directly for the last 5 years in the Department of Psychiatry at the university in a research capacity, and I also do clinical work at the St. Louis Park Navigate Clinic. And I'm excited to have everyone here this morning. I'm gonna turn it over to Kayla because she was the first to arrive today and she's right next to me.
Hi, I'm Kayla Polson. I am the program supervisor for the Child and Family team up in Duluth, and I also oversee the FEP team up here in the frigid cold. I will pass it to Cece.
Morning, I'm Cece. I'm the IRT clinician at the FEP program up in Duluth. And I will pass it to Danny.
Good morning. Excuse me. Good morning. I'm Danny. I am the Supported Employment and Education Specialist with the HOPE program. And I will pass it to Lindley.
Hi, I'm Lindley Brodden. I'm the case manager with the HOPE program, and I will pass it to Orly.
Thanks. Good morning. I'm Orly Haven. I am family clinician in Navigate St. Louis Park, and I will pass it to Amy.
Good morning, everyone. My name is Amy Fordham. I am a doctoral learner under Piper and serving as an IRT at the St. Louis Park Clinic. And Melissa Rosewall, let's hear from you.
Good morning. I'm Melissa Rosewall. I'm the social work care coordinator at the Navigate program, and I also do therapy in our step down program. And I'll pass it to Bailey. Good morning.
Good morning. My name is Bailey. I am a social work learner under Jules at the Strengths program. I just started, so I'm doing my foundation year, and I will pass it to Zemzem.
Thank you. Hi, my name is Zemzem. I'm also a social worker intern. Working under Melissa at the Navigate team, and I will pass it to Claire if she hasn't gone.
Thank you. Good morning. I'm Claire Moser. I'm a supportive employment and education specialist with the HOPE program. I'll pass it to Laurel.
Good morning. I'm Laurel Bieschke. I'm the program director and family clinician over at the Compass program with Radius Health in St. Paul, and I will pass it to Vic.
I'm sorry. Hi, I'm Vic. I'm the peer specialist at the Hope Clinic, and I'll pass it to Kitra.
Hi, my name is Kitra Nelson. I'm the program consultant for the first episode mood disorder program at DHS, and I'll pass it to Trisha.
Hi, good morning. My name is Trisha. I am an IRT clinician at Navigate in Grand Rapids, Michigan. And I'm sorry, I have no idea who hasn't gone yet. I'll pass it to Nancy.
Morning, everybody. I'm the family peer for Hope, Navigate, and Strengths, and I also work for NAMI, Minnesota. And I will pass it to Elizabeth.
Hi, I'm Elizabeth. I'm one of the IRT specialists at the HOPE program in Minneapolis. I'll pass it to, I think Stephanie hasn't gone yet.
Hi, I'm Stephanie. I am one of the supportive employment and education specialists with Navigate in St. Louis Park. I will pass it to Morale. Have you gone? Marielle, sorry.
Oh, she said she can't get her stuff to work.
Okay, what about Jessica? Erin?
Yeah. Hey, I'm Jessica. I'm a student as well, a first-year doctoral student at the University of Minnesota, and I'm helping with Piper on some manual materials. I'm not doing any clinical work yet, but really excited to be here. I will pass to Nasteha. Have you gone yet?
No, I haven't gone. Hi, everybody. I'm Nasteha. I am also a social work intern in my clinical concentration year with the Strengths program with Jules, and I mainly do IRT with individuals. And I will pass it to Danny. Have you gone yet?
I think Melissa Shedler is the only one left, unless I missed someone.
Okay.
I'm Melissa Shedler. I am the IRT clinician with the Strengths program.
And Marielle, is your camera and stuff working now?
Yes, my glitching has stopped. I'm Marielle. I'm the director and the family clinician for the HOPE program at Hennepin Healthcare.
And I think that leaves us with Christa. It is all yours, so feel free to introduce yourself, and then we will turn it over to you, whatever you have planned.
Awesome. So I am Christa Labouliere. I'm a clinical psychologist at Columbia University. I work with the team that is doing an EpiNet project there, the On Track New York team. And I'm going to be talking today a little bit of some of the adaptations that we have made for risk assessment for first episode psychosis. So I want to start off today that my background is suicide prevention. I work with the suicide prevention training, implementation, and evaluation team at Columbia. We were brought in to assist with the development of an FEP-specific suicide prevention protocol for the EpiNet grant that was awarded to On Track New York. And so that was how I started working with my wonderful colleagues, Alana Nassel, Aruma Bello, Lisa Dixon, and Yale Holschitz from On Track. And I really owe them a debt of gratitude because, you know, I have learned an enormous amount of working with first episode psychosis patients. And really, we've done great work to extend best practices for suicide prevention to a group that traditionally has not been as studied in our protocols. You know, we have lots of evidence on what best practices for suicide prevention are and what we should be assessing. And unfortunately, not all of those research studies were done with folks with psychosis, let alone first episode psychosis. And so that's what I'm here to talk about today, how we can take all of that good information that you learn about suicide assessment when you're taking your classes and learning from supervisors, and then adapt that for the specific needs of folks who have first episode psychosis. And so I'm probably preaching to the choir a little bit when I talk about the importance of suicide prevention for folks with FEP to this group. But I just want to start with setting the context, especially for, you know, folks that are students, folks that are coming in new. Individuals with schizophrenia have a much, much higher risk of suicide. There's a 5-fold increase in death by suicide. A large number of individuals with schizophrenia die by suicide. And the highest risk is during illness onset, particularly after hospitalizations. Even beyond the risk of death, an enormous number of individuals with psychosis attempt suicide as well. Between 20 to 40% of young people with schizophrenia attempt suicide. And the attempts amongst individuals with schizophrenia are often more serious. They may often require medical intervention, and they tend to use more lethal methods compared to the general population. So while suicide prevention is going to be an important emphasis for any work in mental health, particularly when working with individuals with FEP, who are in the earlier stages of treatment, there's an enormously high risk of suicide. And so the emphasis needs to be there. Well, you know, I don't share these statistics to scare you. I share these statistics to really highlight that when we're working with individuals with FEP, we have an enormous opportunity to really make a big difference and prevent, you know, the tragic morbidity and mortality associated with suicide. And so since we know that individuals with psychosis are at heightened risk for suicide and that risk is even higher during the first episode, that's giving us a really good opportunity to work to make a difference. Unfortunately, the next question is, you know, then what do we do? And the problem is that current best practices for suicide risk assessment were not always designed with the needs of individuals with psychosis in mind. And so the recommendations that I'm providing here today come from a number of sources. Certainly, they come from the literature and best practices recommendations for suicide assessment. But part of our work for this EpiNet project that we have been doing is that we really wanted to leverage our healthcare system, leverage the wisdom of the On Track network, and also consult with folks across the country, across the world who are experts in this area, so that we could really compile what are the specific needs of folks with first episode psychosis. And I want to give a particular plug to the valiant On Track clinicians, various team members, peer specialists, and also On Track participants, clients with lived experience who participated in qualitative interviews with us to really help us flesh out, you know, what was missing from our existing protocols and what we could do better to really help serve the needs of this population. And so before I go any further, I just want to get everybody on the same page when it comes to definitions. Most folks are very familiar with the idea of a suicide attempt where there is a deliberate action that a person takes. And this has at least some intention to end their lives. It doesn't have to be 100%, but there's some intention there to die. There's a broader umbrella category of suicidal behaviors. These are any actions that are taken towards a suicide attempt. So this is going to include suicide attempts, but it's also going to include things like preparatory behavior, like a person gaining access to means, writing a suicide note. It's going to include things like interrupted or aborted attempts, where maybe a person starts to do something to end their life, but maybe a family member comes home from work early, or maybe they start and at the last minute they stop themselves. Any of these behaviors that are an action taking towards ending one's life really puts somebody at incredibly heightened risk. And so we don't want to just ask folks about suicide attempts. We want to ask folks about this entire spectrum of suicidal behaviors. That being said, in the population of folks with psychosis, we also have an additional thing that we need to think about. A number of folks with first episode psychosis engage in dangerous behavior, and they're not doing it with the intention of hurting or killing themselves. A lot of times, psychotic symptoms can put people at risk for acting in ways that are dangerous, but they don't necessarily know or realize that it's dangerous. And so if you only ask about, suicidal thoughts or behaviors, a person may not disclose if they are having delusions that could be pushing them to do something more dangerous. So we've worked with people who thought they were able to fly, and so they jumped off a building, or they had beliefs that if they cut themselves, they could remove the recording device that was implanted. And as a result of these psychotic symptoms, delusions, hallucinations, disorganization, they were more likely to do dangerous things, but not necessarily dangerous things that they would identify as being behaviors where they intended to end their life. And so it's very important when we're working with folks with psychosis or even at high risk for psychosis that we're also asking about these kind of behaviors, because these kind of behaviors are less likely to come up in our traditional suicide screening and risk assessment, but they're actually, highly prevalent in this population, and we really need to be on our guard. So when we're talking today, we're going to be talking about both suicidal self-harm, but also about unintended self-harm that might be resulting from dangerous psychotic symptoms. So our recommendations, for the On Track program is that we do universal screening and risk assessment for all of our FEP patients. That's probably true for you guys as well. Ultimately, all first episode psychosis patients have some degree of risk relative to the general population, and even relative to the mental health population. So regular screening, risk assessment, and monitoring really is necessary to make sure that they are going to be safe. We try our best to identify who is also going to need a higher level of care relative to other FEP participants. So when we are doing our risk assessments, our guidelines here are not going to be assessment, just for the purpose of assessment. It's really going to be to guide our triage and treatment decisions so we can determine who really needs specialized suicide-specific care and a greater intensity of care in order to maintain safety in our outpatient settings. And so the way we start with universal screening. And ultimately, one of the most important ways that you can identify if somebody is at risk is by asking them directly about their thoughts and behaviors. Due to the heightened risk of suicide and unintended self-harm in this population, we really should be asking everyone, regardless of what we think their risk status is. Everybody should be screened at intake, and we recommend at least quarterly a re-screening with an evidence-based screener so that we can keep that vigilance up throughout the course of treatment. Sometimes we remember, we always do this at intake, but then as time goes on, if somebody's doing well, we might shift to other goals, and that vigilance sometimes drops during the course of our treatment. And that puts the burden on the person to disclose if these thoughts are to come up, which can be very challenging. So we want to make sure that we're checking in with folks throughout treatment on a regular basis so that everybody has the opportunity to disclose if needed. Ultimately, for our folks that we do identify as being at higher risk, we utilize a high risk list, and we have a high risk list for a number of different things. But for our high risk list of folks that are on the list, particularly for suicide and unintended self-harm reasons, we screen them more frequently. So usually weekly, sometime or at every clinical session, depending on how much contact they're getting in a week. And so how do we begin the conversation? Ultimately, a lot of times when people hear screening with an evidence-based tool, they're thinking, oh, I have to pull out this piece of paper and fill it out, and it's just a form. And really what I want to emphasize here is that the purpose of screening is to be a clinical interaction. And so we need to be using a client-centered clinical approach. We really need to be building a relationship with people so that we can encourage disclosure by building rapport, being collaborative, and we really want to be striving for our own understanding and respect of our clients' experiences. This is going to allow us to build a relationship where we can talk about tough things. We want to ask about suicidal or unintended self-harm thoughts and behaviors the same way that we ask about any other sensitive subject. We talk about a number of sensitive things with our clients. So we want to be matter of fact, but we also want to be warm, supportive, respectful. We want to not treat suicide as if this is a different, taboo kind of subject. We really just want to ask directly and affirmatively so that people know, what we're getting at. Then if a client does disclose suicidal thoughts and behaviors, we really want to find that sweet spot. We want to take their experiences seriously, but we also don't want to panic. If we panic and we immediately send everybody to the ED, these kind of overreactions can lead to non-disclosure in the future. This can really, sometimes folks are like, well, why doesn't everybody get an emergency assessment? And it's like, this is a great chance for you to consult with supervisors if you are concerned, but not everybody is going to necessarily need a higher level of care just because they're expressing suicidal thoughts or unintended self-harm thoughts. We really want to make sure that we're keeping folks in the least restrictive level of care that's going to keep them safe. And we really want to provide them hope that we can work together to keep them safe in this least restrictive level of care. So certainly hospitalization is needed sometimes to stabilize folks, but a lot of folks are afraid that if they even mention suicidal or violent ideation, that they're going to be taken off to the hospital. And sometimes folks have very good reason for these beliefs. So it's important to kind of set an atmosphere for disclosure where we talk about the spectrum of care and we talk about what our goals are and how being open and honest is really going to be the best way to keep folks safe. And so I'm going to give a plug for the CSSRS. This is the Columbia Suicide Severity Rating Scale. This is an evidence-based screening scale that was developed by folks at Columbia. It has a lot of evidence on, being a good, quick, brief screener for suicidal thoughts and behaviors. It assesses a number of different levels of suicidality, suicidal ideation, increasing in severity, starting with more passive wishes to die. And then if a person answers affirmatively to either a wish to die or an active thought of killing themselves, you can ask more detailed questions about method, intent, plan, to find out more information about the intensity of those ideations. The CSSRS also asks about suicidal behavior, and it breaks it down into those different types of suicidal behaviors so that we can make sure that we are asking folks about this full spectrum. So if we ask folks only about suicide attempts, they may not tell us about the time that they took a gun out, held it, and then put it away, or that they were going to take some pills, but mom came home from work early. So we really want to make sure that we're asking about this full spectrum of suicidal ideation and suicidal behavior. And the CSSRS is the screener is a really great way of doing this quickly and getting a lot of information with, 5-6 questions. That being said, one of the things that is very clear when working with FEP folks is that the CSSRS and these other evidence-based suicide screeners are simply not enough. These screeners are going to do a really good job at tapping into certain types of risk. So certainly your clients that are at risk because they are depressed or hopeless or demoralized, that are identifying as suicidal, those folks are going to ping on the CSSRS. But a number of folks are not going to necessarily think that their behavior is suicidal or dangerous. And so what we did at On Track is we included questions about unintended self-harm to also get a better assessment of risk. So we developed the self-report tool that was based on the questions of the Columbia Suicide Severity Rating Scale, but also incorporated some other questions from the self-harm assessment tool, interviews that we did with clients, really going back to our stakeholders, like what sort of questions, what sort of information would you want as a clinician? What sort of questions would have got at this for you as a client when you were feeling this way? And so we developed this tool that has similar skip logic to the CSSRS, but it asks about suicidal and unintended self-harm ideation and behavior. And it gives folks a chance to describe what's going on. We have two different versions of this. So there's one that you can use at intake that assesses lifetime and recent thoughts. There's one that you can use, kind of since the last screening as an ongoing monitoring tool. And we are piloting this now as part of our EpiNet project, with the client completing the self-report screener at the beginning of each session and results being sent directly to the clinician. So that way, if anything of concern is coming up, they can discuss it during that session and really handle it right away. Some additional considerations for universal screening when working with this population. Certainly, due to the nature of psychotic symptoms, many times our clients are going to need more rationale and explanation for why screening is done. All clients are going to benefit from some psychoeducation about why we're doing screening, why it is important to be vigilant about these matters, but especially with this population where there can be increased paranoia or mistrust, we really need to make sure that clients understand that a number of people in this population experience these thoughts. And so we take it very seriously, and we're going to ask about this frequently. It's not because we forgot your answers from last week. We remember the stuff you told us, but this is stuff that fluctuates over time. And we want to make sure that if there is anything that needs to be addressed, we are tapping into it and we're following it and paying attention to it throughout the course of treatment. Sometimes we might also need to alter our clinical behavior. I've worked with clients where if I am doing the screener on a computer, they're really stressed out about that. They are very paranoid about the idea of things being put into the computer, or they don't like filling forms. Sometimes this can trigger folks' delusions or fears. And so maybe we need to do this more of an interview style, or maybe they're more comfortable with a self-report. We might need to be flexible in the ways that we approach these clinical interactions so that we can make our clients comfortable enough to actually disclose the information that we need. There are also sometimes cognitive deficits that are present when it comes to folks with psychosis. So we need to be familiar with the questions that we're asking on our screening tools. We need to be able to rephrase them, explain the constructs, break them down if folks aren't getting it, and really present information in a way that's easily understood. We want to be checking in with our clients and making sure that they understand what we're asking and why we're asking it. And lastly, we also want to work with collaterals to corroborate this information. So kind of an ongoing theme here is, especially when working with folks with first episode psychosis, like there's an enormous value of integrating family members, other supports that are in their lives. And of course, we need, client permission. If folks are adults, we need their permission in order to include other folks in their treatment or assessment. But if we are able to, work with a broader team of providers, work with their broader support network, we can usually obtain better information, and we can usually do a better job of providing a safety net for folks. So screening leads pretty neatly into comprehensive suicide and unintended self-harm risk assessment. Now, while clinicians are predominantly responsible for risk assessments in the On Track program, we have a number of team members, and I heard from a number of different team members on your team as well. So I was really excited that there's a bunch of folks here today. And ultimately, even though you may not be responsible for risk assessment, it's very important that everyone on the team be aware and vigilant for risk factors and warning signs so that they can report back to the team. It is entirely possible that a client may disclose different things. They may feel more comfortable with certain team members. Maybe they're more willing to disclose to a peer specialist than they are to their clinician that they don't know as well. And so we really want to make sure that even if you're not responsible for risk assessment, everybody is on board with paying attention to this stuff and reporting back to the team. So risk assessment should be occurring for every participant at intake. Also, anytime you're finding someone who screens positive at some point during their treatment, and of course, as indicated, anytime your spidey sense is tingling, that something feels off, that you're concerned about this person, that should also be triggering a risk assessment to trust your judgment. Now, I call this a comprehensive risk assessment because I mean that we're not just asking about suicide and unintended self-harm. We're going to be asking about a number of different categories of risk factors and protective factors, because this is going to give us a context for determining who is going to be at risk. So there are certain demographic factors that put folks at higher risk. There are diagnoses, there are symptoms of concern, their treatment history or family or social factors, and certainly access to means can be large determinants of whether or not somebody is at risk. So we shouldn't just be asking them those suicide and unintended self-harm screening questions. We should also be asking these broader perspectives, because just because a person denies suicide or self-harm, this doesn't necessarily mean that he or she is not at risk. We really need that broader case conceptualization to optimally determine someone's risk. Individuals with FEP may be at elevated risk for suicide or unintended self-harm, even if they're saying that they've never had those thoughts. There's a number of reasons why people may deny thoughts. You know, maybe they don't feel comfortable enough to disclose that to you yet. Perhaps they're paranoid. Maybe they're motivated to obscure their symptoms because they don't want to go back to the hospital. So there's a number of reasons why folks may not tell you on that first intake visit. Even beyond that, it's entirely possible maybe they're not having those thoughts today, but they could be one acute stressor away from having those thoughts. And so just because they don't have ideation today doesn't mean that they won't tomorrow. And we really need to understand the setting environment that could put a person at greater risk. This risk is not static. It's going to fluctuate over time. And so assessment is not a one and done. This is the sort of thing that we start at the beginning and that we update with all of the new information that we obtain from our clients throughout the course of treatment. That vigilance is going to be incredibly important. And ultimately, the goal of this assessment is going to be to help you anticipate crises and put measures in place to maintain safety. So we don't want to be reactive, we want to be proactive. We want to make good triage decisions so that people are able to get the level of care that they need in order to stay safe. We want to target their treatment planning based on what we learn from our assessment, and that way we can hopefully reduce their risk factors and enhance their protective factors in a manner that will keep them more safe. Now, all of the things that you learned in your graduate school risk assessment training, all of that stuff still applies. You know, just because a person has FEP doesn't mean that those diagnoses, those symptoms of concern that you associate with suicide risk assessment do not apply. So if you're seeing somebody who is depressed, who has a lot of anxiety or irritability, they're withdrawing from family or friends, if there's a lot of impulsivity or externalizing high risk behavior, anything that's an abrupt change, certainly recent traumatic experiences, substance abuse, or emotion dysregulation, all of these things that would put any mental health patient at increased risk are still going to apply in the context of FEP. The same is true about red flags when it comes to psychiatric or substance use treatment history. If a person is not voluntarily coming to treatment, if they have been dragged by their family or because of legal entanglements, that may suggest that they'd be less invested in treatment. If they've had negative previous treatment experiences, if that previous treatment was not what they hoped for, that can be a bad sign. And certainly we want to check in not just about the client's attitudes and beliefs, but also their broader support network. So if they're living at home with their family, or if they have a natural support network that they're connected to, what are their attitudes and beliefs for treatment? Further, just like assessment with any other mental health population, we want to be checking in about their family and social contexts. Conflict with families, friends, or a significant other is a potent trigger for suicidal crises. Folks that have experienced trauma, abuse, or neglect, episodes of bullying, victimization, or discrimination, all of these things are common triggers for suicidal crises. There's also disciplinary problems. If they're in school, perhaps poor performance. If there's been exposure to suicidal ideation or behavior in a peer group, or folks that are experiencing social isolation, either through their own withdrawal or by exclusion or rejection from the peer group. We want to be very sensitive to recent precipitants or triggers in a person's life, whether that may be a recent experience of loss, a recent experience of failure, or a recent life stressor, especially traumatic stressors. And lastly, we really want to check in regarding access to meetings. So with any patient that came into our outpatient clinic, we would be checking in about these things. These are pretty standard categories that we want to make sure that we are assessing in order to get a good comprehensive picture on somebody's risk. Lastly, it's not all doom and gloom. We also want to be assessing for protective factors with everybody. Does this person have reasons for living? Are they deterred from suicide because they feel that there would be a negative impact on their family or friends, or they have responsibilities to others? There are lots of things that can help keep a person connected to life. And so we want to understand not only their reasons for wanting to die, but also their reasons for wanting to live, because these can be potent when it comes to our ability to help facilitate treatment and help engage folks with a life that they want to live. So that's all the risk assessment stuff that probably sounds very similar to every risk assessment conversation you have had in your previous graduate school experiences and your previous work in outpatient care. But what about FEP? FEP is a little bit different. And so we really wanted to speak to participants with lived experience and ask them directly, where did the mental health system miss this? What can we tap into that would have helped identify this for you earlier, that would have helped connect you to the help you needed earlier? And certainly we received the information that we really need to ask about both suicidal and unintended self-harm risk. Folks who are experiencing delusions or psychotic symptoms are often deeply distressed, but won't necessarily think of that in terms of the harm it could create to themselves or others. So we really want to create an individualized profile for this person, including information on both suicidal and unintended self-harm risk. We also really want to emphasize engaging family and support of others so that we can obtain that collateral information. So as long as folks are amenable, speaking to family members about their concerns, providing psychoeducation to family members so that they can help report back to the team, can be a really great way to offer support to folks when they're out in the community. We can't be with them 24 hours a day. And so if we can help their natural supports to identify things that could be a red flag and know what to do, then we as a team are going to have much better information. We also need greater awareness of FEP specific risk factors. There are certain things about the nature of psychosis, particularly first episode psychosis, that can lead folks to consider suicide or be at greater risk for harm. So sometimes in this population, greater insight greater understanding of their symptoms can lead to demoralization or hopelessness. Folks sometimes feel after receiving a diagnosis that their trajectory has been derailed and can become very hopeless about the future. And so we want to be aware of that and really provide a recovery orientation. Certainly experiences of medication changes, anytime somebody is switching medications, discontinuing, adhering poorly to their medications, that is a time of increased risk and a time of concern. Anytime we're working with somebody who's having an escalation of psychotic symptoms that could lead to dangerous behaviors. So if there's an increase in command hallucinations, an increase in paranoia or disorganization, we really want to be paying attention to that. Anytime a person perceives their psychotic symptoms as intolerable and they want to escape, that feeling of being trapped and wanting to escape is a common trigger for suicidal crises. And a lot of times psychosis can lead to agitation or panic and, sleep disturbance, things that can be a really, intense environment, and folks will act in a manner in order to escape these sensations. Lastly, a lot of times when folks come out of their psychotic episode, there's a lot of consequences. Maybe they were fired from their job, or, they had to leave school, like folks might have, alienated friends and family. And so sometimes there's this feeling that they really are just not going to be able to overcome these consequences of the things that they did when they were psychotic. And these were things that folks with lived experience and their clinicians were really highlighting as being specific to the FEP experience and being really important warning signs to be on the lookout for. That being said, there were a number of suicide risk factors that are risk factors for everyone, but there were also endorsed as being particularly salient for the FEP population. So things like increases in substance abuse, agitation, sleep disturbance, these are all things that would make us worried about any client under our care, but particularly for folks with FEP, this can be a warning sign of an upcoming crisis. We want to be very careful after large life events like traumatic events or care transitions, even positive care transitions, sometimes even moving to sometimes even doing very well in treatment and approaching the end of the program can be a trigger for folks to start thinking about what's coming next. And that can be scary for some folks. We really want to be working on feelings of isolation, feelings of hopelessness, feelings like this disorder could potentially make them a burden to their family or friends, or feeling trapped by their symptoms. While these are things that are true for most mental health disorders, they were particularly salient for FEP. And so one of the things that we found was most important was to provide psychoeducation on this information. So not just giving a risk assessment where we ask about this stuff, but also making sure that all of our team members are aware of these warning signs and communicate, and that participants and their support receive this psychoeducation on psychosis and suicide risk. We want them to also know what these warning signs are, how suicide and unintended self-harm can fluctuate, and what the treatment options are, so that a family member who's worried or a participant who starts having some scary thoughts can really understand what the options are, what our approach will be, so that we can prepare for this ahead of time, not when a person is in crisis. And so we prepared some materials with this FACTS acronym. This stands for feelings, actions, changes, talking, and situations. And we prepared some psychoeducation that we review with everybody who comes in as kind of a universal precaution. These are some things that sometimes, we highlight the things that might happen, as a result of experiencing psychosis, and things that we really want to keep an eye on so that we can make sure that we can actively intervene before things get too bad. Then, based on these conversations with participants, their supports, based on our risk assessment, we want to make sure that we're doing a good level of care determination. This is a great time to check in with your supervisors. Remember, like, risk assessment is nuanced. It's going to require your clinical judgment. There's no algorithm here that you can add up all the numbers, because different risk and protective factors mean different things to different people, and risk fluctuates over time. So this is something your ability is going to improve with experience, and you should really capitalize on the wisdom of your supervisors and your team. With that being said, for the On Track program, we have determined that there is really nobody with first episode psychosis who is at low risk relative to the general population, and even relative to other mental health populations. By nature of having psychosis, they are at increased chronic risk. And so we usually do our level of care determination between who's not currently at elevated risk and who is currently at elevated risk, so that we can provide a triage protocol with information on how to determine between these two levels and how to guide suicide-specific interventions based on a risk level. We typically state that the folks who are not at currently elevated risk have no acute warning signs present. There's not a lot of ideation or intent. There aren't psychotic symptoms that are currently likely to result in dangerous behavior. And these folks will usually have more protective factors or symptoms that are less prominent or more manageable. For our folks that are currently at elevated risk, these are going to be folks that have numerous symptoms where the risk factors are outweighing the protective factors. There may be suicidal intent, there may be violent ideation. This could be a person that has access to means or could easily obtain access to means. And any of those FEP specific factors that we were talking about, like command hallucinations, disorganization, erratic behavior or agitation, or significant distress or hopelessness from their symptoms, these are all going to be signs that a person may currently be at elevated risk, and they may need a higher level of care. Not necessarily in the hospital, but within our program, we may be needing to provide more frequent touch, more suicide-specific interventions. Ultimately, the goal of our assessments are to inform our interventions. The risk level you assign is going to help you determine the most appropriate interventions. There are going to be some things you need to do immediately in order to maintain safety. Sometimes this might mean if somebody's at imminent risk that they do need a higher level of care like hospitalization, but very frequently things like safety planning, means reduction counseling, these kind of suicide specific interventions can help us keep clients safe in the community. We also want to be thinking about the longer term interventions that are going to address not only the psychotic symptoms, but also suicide and unintended self-harm risk across the course of treatment. We really want to determine, we really want to determine if the client is going to be appropriate for enhanced care. And so the way that we do this for the On Track program, we have this suicide and unintended self-harm pathway. And folks are placed on this pathway if they have had suicidal or unintended self-harm ideation with intent or plan, or suicidal or unintended self-harm behavior in the past 90 days. So those would always trigger somebody being put on the pathway, but we do allow for clinical judgment. If somebody doesn't meet this threshold, but you're feeling nervous, absolutely go ahead, put them on the pathway if you feel so. We also want to keep folks on the pathway for an extended period of time where they get this higher level of care, they get this suicide-specific interventions, more frequent clinical contact, more frequent monitoring, and we provide this level of care for at least 90 days until that suicide or unintended self-harm risk drops. And so our clinical protocol derives directly from our assessment. If somebody's not at currently elevated risk, we believe there's a number of universal interventions that everybody might benefit from. Things we've mentioned already, like psychoeducation, family involvement, integration of peer support. But if somebody is at currently elevated risk on that high risk pathway, we have more suicide specific interventions that we recommend. Things like safety planning, suicide specific treatment planning, increased clinical contact, and possibly optimizing psychotropic medications to enhance their suicide prevention potential. We also have different monitoring protocols based on that level of risk we determine. So again, we have universal monitoring for all participants. So we make sure that everybody will be rescreened at least quarterly. And we also make sure that everybody will be prioritized for clinical care within 72 hours of a care transition or acute life stressors. That being said, for our folks who are at currently elevated risk, we screen more frequently, usually at every session or at least weekly. And if folks are experiencing a care transition or a missed appointment, we make sure that we're doing same day contact just to make sure that they're safe. So ultimately, I don't like to talk about assessment without giving an idea of that through line through. What is the point of this assessment? And the point of the assessment is always so that we can triage and provide the best possible level of care to meet the needs of the folks that we're working with. And so that's why I give you like kind of a brief overview of our protocol, because based on the information you learn, you can continue to integrate assessment into the interventions that occur throughout the course of your treatment. And so, questions?
We will open the floor. So anybody who has any questions, Melissa Rosewell was asking one of the questions I had, which was, can we get a copy of your slides?
Yes, I apologize. I tried to send them yesterday and I guess the pictures were too big. So I'm going to compress them and then I'm going to send them to you in a reasonable format.
That works. That works. Thank you very much.
Good morning. Hi, thanks, Christa. This is a fantastic topic. And similarly, I'm a family clinician at St. Louis Park. I love psychoeducation, love doing it. And I often talk about this with family, of course, because it's important, but I sort of wing it every time and adapt it based on what the family already knows, et cetera. Wondering if On Track New York shares their psychoeducation material, that FACT acronym. Do you have any other written materials for work with family that could be shared? Would love that.
We are actually working on it. And so my hope would be that by the end of our EpiNet pilot, we will have written materials. We're at the point where we have written materials, but they're still being reviewed and revised by our stakeholders. They're not quite ready yet. But absolutely, I'm going to share these slides. Feel free to, our written materials focus on the FACT acronym. We use that. We're trying out different approaches. So maybe like some brief videos, like YouTubers, TikTok style videos, for our younger participants. Because, we kind of started out with like boring handouts, but nobody wants to read that. So we're trying to see if maybe more of a testimonial approach or psychoeducational videos might work a little bit better. So yeah, we'll report back. We're trying out some stuff.
Thanks so much. Appreciate it.
I have a question. Thank you. This was great. And in Minnesota, it is in the Midwest, there is a big cultural piece related to having guns in the home. Lots of folks that I work with have access to guns. And other than putting a lock on it and not having access to the code, which, a lot of times families say that's the case, what other recommendations might you have about folks who do have easy access to guns and ammunition and supporting folks around that?
Yeah, prior to my time in New York, I spent some time in Ohio, so I'm very familiar with that Midwestern love of guns. And even, while New York City is very tight on gun control, I feel like upstate is actually, we got a lot of guns up there too. And so yeah, this is an issue because a lot of times folks also have very valid reasons for wanting their guns. It's related to their identity. They feel very strongly about having their guns, or maybe a family member's a veteran or works in law enforcement. There's a lot of reasons why getting rid of the guns is not always a feasible option. So I usually couch this in terms of firearm safety. We've even done work with local shooting ranges and, you know, like law enforcement teams to really just discuss safe ownership of a firearm. Having a firearm in the home means greater risk of accidental or suicidal injury. And so considering that is part of firearm safety, and most folks who are responsible firearm owners are invested in firearm safety. And so I usually go with the conversation, go to the conversation from that angle, because this is usually less likely to trigger that, like, you're trying to take all my guns fear. Which I think a lot of times, the mental health system has provoked that fear. We try very much to be creative. When it comes to means reduction, it is a negotiation between me, the client, and sometimes their family. And so what is the safest and most feasible thing that you are willing to do? I've had folks that have disabled the firing pin on their gun. I've had folks that took out all the ammunition and gave it to a friend. So that way, if they still needed the gun for protection, they could brandish the gun, but it wouldn't be loaded. I have had, like gun safes, gun locks, sometimes even moving the gun to a less close location. So like, could the gun be in a safe in the garage rather than in your bedside table? Certainly, I would rather the gun be unloaded or removed from the home or locked up, but even moving it to the garage in a lockbox is more steps and more time than keeping it in the bedside table. And so my perspective is whatever, any step and any time that a person has between themselves and a very lethal mean is going to be helpful. And the plan that they actually do is safer than the plan that they say yes to and then go home and just don't bother doing it at all. And so I really try to make this a negotiation. If somebody is not willing to do anything at all, then that may be indicative of needing a higher level of care. I don't know that I'd be fully comfortable if they're like sleeping with a loaded gun under their pillow and they're not willing to do anything. But usually when discussing firearm safety, reminding folks that this is for a limited period of time until risk decreases, usually I get some buy-in. Okay. And then just revisit, make sure, this is the means reduction plan for today. Is it maintained? Or did they take it back out? And are they more willing, maybe a week from now, they're more willing to, maybe as time goes on, they develop a bit more insight, they come to trust you a little bit more. Maybe what the most feasible plan for today could be a little bit better next week.
Great. Thank you so much.
Thank you, Christa. This is a wonderful presentation. I apologize because I know there's probably more questions, but I want to